Good afternoon, and thank you all for joining the Maternal Health Equity Supporting Community and Structural Interventions webinar. My name is Miriam, and I'd like to review some quick housekeeping notes before we begin with today's content. Firstly, I would like everyone to know that this webinar is being recorded and will be made available for all attendees after today's event. All attendees can connect using audio through their computer or using the WebEx Call Me feature to receive an automated call from WebEx. Live captioning will also be available during this event. To view or hide these captions, you can click the closed caption button on the lower left-hand side of your screen. It should be a little CC with a little text bubble around it. Click the small arrow beside that closed caption button to select your preferred caption language. And then before we move forward, I'm going to let Jody introduce herself and get us started with today's agenda and webinar.
Thanks, Miriam, and welcome everybody. I'm Jody Anthony. I'm really excited about today's discussion because after I set the context, we will have the opportunity to hear from three of my esteemed colleagues and friends who have been working at the intersection of community health, health equity, and maternal health. They will be sharing their insights about how to effectively support communities to address maternal health and health inequities. And this is going to be a roundtable discussion where audience participation is highly encouraged. Next slide. So just to level set, as many people on this webinar know, the United States has the highest rates of maternal mortality and morbidity among all developed countries. These rates have been increasing over the last couple of decades, and there are significant disparities for non-Hispanic Black, non-Hispanic American Indian, and Alaska Native and rural populations compared with other populations. Next slide. Most maternal deaths, about 80% of all deaths and 90% for American Indian Alaska Natives, are preventable. Mental health conditions are the leading cause of preventable maternal deaths, and provider-related factors, such as the lack of identification of high-risk status and delays in diagnosis and treatment, are the leading causes of maternal morbidity. Next slide. We included this slide to really hit hard, pun intended, about the complexities of these inequities. Serena Williams is arguably the greatest tennis player of all time. She has 23 Grand Slam singles titles, is the highest earning woman athlete of all time, and yet in 2017 she had a pulmonary embolism after the birth of her daughter. Research and people of color's lived experience demonstrate that Serena Williams' experience is not unique. Next slide. The inequities in maternal mortality and morbidity are largely caused by how social exclusion, economic disadvantage, and political or geographic marginalization are embodied throughout a person's life and across generations. Examples of historical policies and racist structures include enslavement, lack of voting rights, extinguishing Native cultures through boarding schools of American Indian and Alaska Native children, taking of indigenous lands, forced sterilization and eugenics, and the list could go on. These historical factors are then compounded with current social determinants such as racial and economic segregation in housing, hospitals, schools, and communities, racism, sexism, ableism, other isms, and discrimination, environmental hazards and climate change, and inadequate or degrading healthcare and behavioral health services. Broadly, we refer to these causes as the social and structural determinants of health. Next slide. To address these inequities, there needs to be action for individual health while also addressing the root causes of inequities within the community and the society more broadly. At the individual level, it should be assured that pregnant people encounter healthcare providers who listen and respect them, and that their health, behavioral health, and health-related social needs, such as housing, food, and safety, are addressed with a multidisciplinary, culturally concordant team that includes midwives, doulas, and community health workers. Next slide. Pregnant people should live in communities with low pollution levels, safe streets, and access to healthy foods, to name a few. Next slide. And at the state and federal levels, the U.S. should have poverty alleviation policies and funding for good schools and provide affordable health insurance throughout a person's life. Moreover, the structures and social hierarchy of racism, sexism, and classism must be dismantled. Next slide. The White House Blueprint is a significant effort to address the maternal health crisis. It identified strategies and funding priorities to improve respectful, quality, accessible, risk-appropriate services and create continuity across healthcare, behavioral health, and social service settings. Examples of some of what's listed and included there is expanding the maternal mortality review committees by the CDC, extending postpartum Medicaid coverage, and creating birthing-friendly hospital designations by CMS, to establishing a maternal mental health hotline and creating community-based doula programs by HRSA. Next slide. Much of the successful implementation of these federal investments requires effective partnerships with community-based organizations serving those communities most in need. Community-based organizations, or CBOs, are led by communities experiencing the inequities, like community-based doula programs, federally qualified health centers, community hospitals, and birth justice organizations, and they are essential to understanding the causes of health and inequities and to crafting meaningful policies and practices. However, CBOs are asked to wear multiple hats, often with few resources. They likely sit on several community boards. They may not have a well-established grant writing or data system, and they have limited time or resources to proactively identify new sources of funding or partnerships. Additionally, some CBOs have their own internal social justice and diversity challenges. So, all of that to say, the key questions are: how do we assure available, accessible, culturally respectful, quality care while also addressing the social and structural drivers of health inequities? And what are effective strategies to build community-based organizations and collective power? Next slide. Today's panelists, so excited, have dedicated their careers to advancing community health, and they will share their insights with us. Kelly Wagner is a principal associate at Apt Associates with over 22 years experience in the provision of culturally competent technical assistance training and capacity building focused on addressing health disparities and enhancing health equity. She has developed and implemented multiple national TA and training programs for federally funded awardees, including community-based organizations, community health centers, academic institutions, and state and local health agencies. She currently leads a national coordinating center focused on strengthening the system of care for sickle cell disease. Nicole Purnell is a maternal health advocate based in North Texas. Her life was tragically changed in 2005 when preeclampsia and HELP caused multiple organ failure, placenta abruption, and resulted in the stillbirth of her son at 34 weeks gestation. She began volunteering with the Preeclampsia Foundation soon after, and in 2018 joined the staff at the Preeclampsia Foundation as the Mama's Voices Coalition Program Director. And last but not least is Nicole Clark, who is a licensed social worker and owner of Nicole Clark Consulting, where she partners with mission-aligned, BIPOC-centered, women-led, and allied organizations whose work supports the lived experiences and advancement of women, girls, femmes, and gender-expansive youth of color. Using a reproductive justice-informed and intersectional approach, Nicole leads partners with and consults on projects related to participatory research, program design, strategic planning, and culturally responsive and equitable evaluation. So I have a few questions teed up. Thank you to the participants who already shared their questions when they registered. We'll go through those, then we'll open it up to people from the chat or if you want to come off mic. And so at this point, we will stop sharing slides and provide space to see and hear each other. So hi, welcome. Thrilled to have you here. Let me start with some really big picture, just level setting questions to get us all on the same page. And so I just want to start with this big concept of social and structural determinants of health. And I named a lot of things, but underlying these issues are mental models, cultural beliefs, social norms that I'm really curious, and will ask each of you in turn to, to just share what you think from your experience. Are those systemic issues or cultural beliefs that we need to name, elevate, and address to really move the needle on maternal health? Big question. You can, I'm going to start with Kelly.
So thank you, Jody, and welcome everyone. Thank you for inviting me to this panel, Jody, as well. One of the things, when we talk about the cultural norms or models or beliefs that I think about that truly impact maternal health specifically for women of color, and even more specifically for Black women, is the schema or the idea, the cultural belief of the strong Black woman and the superwoman, and this idea that Black women possess this unyielding strength, this expectation of suppression of emotions, the assumption or obligation for multiple roles, and the idea of caregiver first. And I think that while oftentimes, this strong Black woman schema or superwoman schema has the benefits around self-preservation or preservation of, continuity of the community and the family, that it truly does not only impact health behaviors such as delaying care, but also impacts perception of Black women's ability to manage pain, um, from providers. You mentioned Serena Williams, and I remember reading the article when she was first talking about her experience, and she talked about speaking to the providers about her history and explaining that she was in pain and explaining that she understood or had some knowledge around this condition and that it wasn't addressed or attended to, um, in a way that really, should have been, given the fact that she was explaining this. And so I think that, that idea of super Black woman, superwoman in general, is one of those cultural beliefs that can impact how uh, women experience care and experience adequate care within the health system.
Thanks, Kelly. How about Nicole C?
Can everyone hear me?
Yes.
All right, perfect. All right, thank you to App Associates for inviting me to be here today. As Jody mentioned in my introduction, I am a social worker by training and education. I spent the first half of my social work career being more in organizations working one-on-one with individuals, and now I have shifted over the last 6 or 7 years or so working with organizations who they themselves are the experts when it comes to maternal health and birth equity work. And so I see myself more so as a supporting player to the organizations that are really trying to move the needle to advance maternal health and birth equity in their communities. And I think touching on what Kelly said, I'm currently working on a birth equity project with the foundation, and they task us to identify ways that this foundation can better invest in maternal health and birth equity work. And one of the findings that came from this project was developing a better way to provide more accountability from the hospital system. And in addition to maternal mortality review boards, what are the ways that we can develop feedback mechanisms that encourage patients and support systems to share the experiences that they're having when they go to their prenatal and postpartum and birthing experiences when they're inside of the clinics and the hospitals? And I think that this could be a way of engaging and empowering patients, which also can improve the quality of care. I think a good example of that is the Earth app. I don't know if anyone is familiar with the Earth app. The Earth app was developed by Kimberly Seals Ayers and is for pregnant people and their supporting partners. And this could be a married partner, a family member, someone else who is helping them. It could be a doula as well, who can give reviews on their engagement and their experiences inside of various hospital systems, hopefully in a way that helps to build out accountability for learning about how to improve maternal health outcomes as well.
Thanks. And that's actually a great segue to Nicole P.
And again, thank you for having me here. I'm excited, and I have been through this whole process of just being able to join these other fantastic panelists in this discussion. I think one of the things that I see and I feel too is to go on with Kelly's comment about being a strong woman, being a strong Black woman, is that there is a tendency in the culture to talk about resilience and snapping back. And I think that is such, to me, that's an R word, and it's a 4-letter R word. I hate the word resilience because I think it sets up those that have had a lived experience, have had a traumatic birth, to feel like they have to move on from it and they have to forget that maybe happened, when reality is that it potentially changed their life. And that's where a lot of folks get involved in wanting to be a patient advocate or getting involved in creating community-based organizations, is through their lived experience. And those CBOs really are pockets of those with lived experience. I want to do something and make a difference for other people. And so I think if we focus so much on that resilience factor, we lose part of that aspect of why people have gotten to where they are and what they're doing with it.
That's great. And so I'm going to keep with the questions, but I encourage you all, like all of our practice sessions and our planning sessions, is to comment as well on what you're hearing. So this is also, you led me into the next question that we got, which is really about like, why CBOs, why community-based organizations? Like what is it about them that makes them uniquely situated to advance maternal health and health equity? So does anybody want to start?
It's like, I'm happy to. So we talk about, there's a lot, you might have heard like, no decisions about us without us. And that's kind of across the board. And we at Mama's Voices have a very big, we want patients to be involved in not just the decision-making process, but the design process. And so oftentimes being able to connect with community-based organizations, whether they are, community-based organizations by definition are really local, right? But every state has different demographics. They have different geographies. They have different things that they're trying to work through. It goes from state to state. It goes city to city. It can go neighborhood by neighborhood. And so being able to really connect with those people that you're trying to serve that look like your waiting room, walk into your waiting room, and what does that look like? And that's what you want to be involving in your process. And they want to be a voice and to help bring those solutions forward, because they probably already have the solution and have the answer. They just need to be asked and given that platform and space to share with you what they're doing.
That's great. Anybody? Yeah, go for it.
Just to touch on what Nicole said, as a researcher and evaluator, I tend to rely very heavily on community-based organizations to even be allowed essentially to go into the community to collect different types of data. I feel in a lot of ways that community-based organizations are better positioned to address maternal health disparities because more often than not, they do have the trust of the communities that they work in. And even if they have an explicit focus on maternal health, more often than not that they are connected to like WIC offices, places of worship, schools, and things of that nature. And I would say that they would have a stronger blueprint for building community partnerships. And that can sometimes take years for much larger institutions like academia, hospitals, the health department, and even funders to be able to penetrate. One of the things that I've learned from community community-based organizations over the years is that there's often a frustration when someone like myself, who is a researcher or an evaluator, comes into the community to collect data. There's never a mechanism in place for them to return back to the community to report on what we're finding. And so I feel that in a lot of ways, CBOs are better positioned to help us to gain the trust of the communities that we're going into.
That's perfect in terms of some of the other ideas I was thinking about. I think the piece around trust is key, especially given what Jody was talking about, some of the history of structural policies or systems or that have been in place where mistrust has been grown, mistrust has been sown in a number of these communities with the health system, with government agencies, with academia, with research. And so being able to engage community-based organizations, not just as trusted community members, but as additional access points, is important. One of the other things that I think both Nicoles, I almost changed my name to Nicole today so we could all be Nicole, is the expertise within community-based organizations. We talk a lot about where there are gaps in resources, and that is very true. There is an inordinate amount of expertise within community-based organizations that can be leveraged to educate providers, to participate in training programs for providers, to educate policymakers, to educate funders on how to increase the cultural appropriateness or resonance of programs that are being developed or implemented within the community. And I think one of the things, Nicole, you mentioned was that feedback loop around data collection. Mm-hmm. Engaging community members, not just to provide the data, but assist with analysis and messaging around data is, that speaks to both their trust, but then also their expertise in understanding what the needs of the communities are, as well as what information is going to resonate most with them.
Great. So I have another theoretical sort of big picture question before we get into how we can support. And this is, it's really about making that shift from focusing on individuals and individual health to really supporting community change or structural change or policy change. And from your experiences, where are, and this is like all CBOs, this is not a homogenous group, I understand that, but like where in general are you finding, is this a cultural shift that we also need, that community-based organizations also need to make, from going from individual to sort of collective, or are they already there and it's the rest of us who need to sort of find our way to start moving and addressing more of the social and structural determinants of health? How about I start with Nicole C.
I think in a lot of ways, community-based organizations aren't just focusing on the individual, they're focusing on the individual, the families, and community members in general. A lot of my work over the last few years has been focused on maternal health, but before that, before I went into consulting full-time, I worked in an organization based in New York City that focused on HIV and homelessness. And at that organization, it showed me that when someone doesn't have permanent housing, when they're dealing with mental health concerns or with substance use, it reduces the ability for them to focus on going to their appointments. I used to have clients that would come in, and earlier on in my social work career, I would focus on getting them to go to their appointments within an organization. It was an organization that had case management, but also had mental health services, and also had primary care as well. But so many of the clients that I was working with, they were dealing with housing. And that helped us to build trust between ourselves and the individuals that we worked with, because we were focusing on what they wanted to focus on, even though the organization was primarily focused on primary care. But we understood that if you don't have all of these important needs in place, then as an individual, you probably won't care about, or you probably won't think about the importance of going to a medical appointment. So I feel that in a lot of ways, community-based organizations, they aren't just focusing on the individual level. Even if they have a focus on maternal health, they may be partnering with organizations that do focus on housing or who focus on the criminal justice system as a way to create various types of wraparound services for the individuals and the communities that they work with.
Mhm. I want to explore that a little bit more, Nicole, um, and see in my mind, I think about helping address an individual's housing needs and making sure that there's good linkages with the local housing authority is like one level. I feel like the next level is like working on housing justice reform, and like how do we support CBOs, and maybe CBOs are already doing it, but like how do we make that leap to go from addressing an individual's housing needs to radically changing a community so there's actually affordable, safe housing, quality housing for people who live in it.
Can I jump in?
Yes,
Just, I
yeah,
think,
yeah.
in thinking about this question, I think that sort of the root of what community-based organizations have always done is think about the community and the greater needs of the community, and whether we call them social determinants of health or structural issues or interventions, that they've been addressing them. They've been looking, as Nicole mentioned, at housing, at food security, at economic opportunities, at educational opportunities. And so I think to your point, where I, at least in my experience in working with community-based organizations across, focusing on multiple um, issues, whether it's HIV or safe spaces or maternal health, is that shift from addressing the need to providing education for policy change that really brings a greater change within the community. Um, in one of our prep sessions, I think we talked about photo voice and the power of having a community member with a camera in their hand shine a lens on the actual experience in which, this experience that they have in their community, and then be able to take that to um, a legislative hearing, or be able to turn that into materials for educating policymakers or even speaking to potential new partners. I think that's where we've seen, or at least in my experience, have seen more growth with moving from addressing the need that is existing to creating a new context in which that need is addressed by a structural intervention or
Yeah.
policy change.
Great, Kelly. Thank you. Nicoles, anything?
I was like, Kelly, I was like, yes, like you have to
Yeah.
attach, like, it's not just the data, but like bringing in the heart to it too, and bringing in that emotion and tying like an actual person's face, an actual person's behind this and behind all these, all this data, all these numbers. And so being able to see past just the end and looking more in depth is so important to be able to push the policy change.
If I could jump back in for 1 second, I think also not only, I can tell I'm excited about this webinar today, not only the policy change, but greater participation in some of the research to develop what's considered evidence. Because when we talk about funding, when we talk about being able to have resources, be seen as an expert. There is this idea of implementing evidence-based interventions, whether at the individual or community level. And so having community-based organizations be more involved in developing that evidence, in presenting that evidence, um, and lending their expertise to ensuring that what's considered an evidence-based intervention is actually implementable within a community context. I think that is another movement from the individual piece to more of the structural or community level engagement and addressing that change that needs to happen in the broader context.
Yes, and hopefully not. There's not everything has evidence based behind it. And that's not because it's not a solution or it's not amazing in what they're doing. There's a lot of reasons why it might not be evidence based. Maybe it just didn't pass through the peer review. There's a lot of things that don't get published, but that doesn't mean they're not quality. And sometimes it's a capacity thing and needing technical assistance to be able to get that published. It takes a lot to write the manuscript, and it might not be in the director of the CBO's wheelhouse or someone that works for them as well. And so being able to offer assistance in that and not holding to just it has to be evidence-based. I'll get on my soapbox there real quickly.
And I think also connected to that is, in addition to getting things published, what are some other ways to get this information out there to community members? I was working on a project about a couple of years ago, and there was a program participant in this project who I believe worked in academia. She was trying to publish some findings from a report that she had worked on, and she was frustrated at the fact that her manuscript was being rejected by all of these academic journals. And so I question, does it have to go inside of an academic journal? Can it be in a blog post? Can it be on social media? Like, what are some other ways that you can get this information out there to the people who need the information? It doesn't necessarily have to always be in an academic journal. There's other ways that community members can share what they're learning about their organization and about their program to people who would be better, easier to engage in places like social media, on podcasts. Podcasts have been very instrumental in getting people to learn and to engage more. There's also YouTube. There's also different ways that you can use like Instagram or TikTok and things like that. So there's definitely a lot of ways that you can get that information out, and it doesn't necessarily have to always be in an academic journal.
Nicole, that's I find that really thought-provoking as well, because what it's also saying is like use data to move your community forward, but we're still with these academic journals. It's like we're taking the data out and creating this other rubric of what is evidence and what makes something meaningful. And it's almost like it's sort of taking it out, whereas what you're suggesting is like, let's keep it in and make it so people who are in the community are actually having access to it, and and they're using it to affect social change, which I think is really important.
And a lot of the information is behind a paywall, which you also have to be mindful of that as well.
I saw somebody in the chat, and I know I have a list of questions, but I just wanted to sort of reflect a little bit on this. And it was about, whether some of the funding, public funding that goes to hospitals can actually instead go to building affordable housing. And it reminded me of the very first job I had that got me into public health was with a group, a health advocacy organization called Healthcare for All. And that was right when there were community benefits and a requirement of making nonprofit hospitals accountable to the communities in which they were housed. And it's like, if you don't have to pay taxes, what are you doing for the community that is supporting you? And trying to actually keep them accountable. And so it became this whole piece on that's sort of how the community benefits. If you know of hospitals that have community benefit departments, it's about how do they actually invest back in their communities. And it's actually a really wonderful way that community-based organizations can start to build some partnership, I should say, with hospitals about how they are using their community benefits dollars and how are they using their nonprofit status to improve the health of the communities in which they are based. Anybody want to add to that while I look at my list of questions? Okay, so this next part is then, okay, we've established it's important to address the cultural beliefs. We have established that community-based organizations are key to addressing social change. How can we support community-based organizations as a large consulting company, as an external evaluator, researcher, as somebody who supports people with lived experience more broadly, nationally? What can we do to support community-based organizations to do the work that they want to do? How about I start? Who spoke? Let's start with Kelly.
So trying to narrow down my long laundry list of ways to support community-based organizations. I want to follow on to Nicole C's comment around different ways to disseminate information. Jody, as you mentioned, my experience, my career has been in technical assistance, capacity building, and support. And so one of the ways is around providing support, resources, and guidance to community-based organizations on strategies to utilize these different dissemination mechanisms, social media, blog posts, podcasts, to use the data that they are collecting about their community and turn that into content that speaks to the needs that can be used both to educate the communities that they're working with, but then also to educate decision makers that need to be involved in either funding new programs or making adjustments to policy or how policy gets implemented, or even organizations that are looking for partnerships. And so I think about that as one way to provide that sort of guidance and support, technical assistance, as it would be to community-based organizations. The other piece was around planning and building partnerships for sustainability. Most of my work has been supporting federally funded grant programs, and a lot of times people think about sustainability as you get towards the end of a funding cycle, whether that cycle is a year or 3 years, and really working with providing support to community-based organizations about how day one, let's put together a plan to sustain what you're doing, not just to sustain this direct funding resource that's coming in, but how to leverage what you're doing now to get new resources, to get new funding, to get new partners, and to sustain your income or the money that you're needing or the resources you're needing, but to sustain the outcomes and the impact of what you're doing. So I'm a huge proponent for support around effective sustainability planning.
Mm.
Yeah, I think for me, connected in that is not only thinking about sustainability, but also thinking about what success looks like for the organization, particularly if, to Kelly's point, if they developed a program that was a direct result into getting funding from a foundation. Unfortunately, I do see a lot of organizations that create a program in response to getting some type of funding. And in the beginning stages of starting the evaluation, thinking about what you want to evaluate. We have conversations around what does success look like for you in regards to this program. And thinking about also, does your definition of success for this program, is it tied into your funders' requests for what they want this program to look like? And that has been something that I've been struggling with, particularly when it comes to evaluation, trying to suss out whether or not the organization's goals are really the funders' goals. or if there's a combination between the two. And I do think as part of being a social worker, a lot of my goal is really on advocating on behalf of not only the organization, but also for the staff who are implementing the program. I think unfortunately with titles like researcher, evaluator, or even consultant, a lot of your word gets elevated in comparison to the executive director and the staff who are leading the program. And so I try to figure out a way to help them determine what success looks like for them and figure out how to address these funder needs as well.
I think something that app can help with as well is continuing to be a champion for organizations, for CBOs to get funding and having these kind of conversations, because I see things where, oh, there's this great grant opportunity available, but you have to have a $2 million budget to even apply. Like, it's so difficult to get the funding that either CBOs don't apply, you don't apply, you know, you can't apply. $2 million budget's pretty significant for a small organization, and a young organization potentially, maybe they're not young, but that's a pretty significant budget for an organization. And so it becomes a cycle of, you don't have the capacity to write for the grants and for the funding. And so then you don't get the funding, so you don't have capacity. So it becomes a huge barrier when it comes to funding organizations and funding CBOs and bringing them into the work, and not just being like bringing into the work, but being in the front of the work as well. So they're not forgotten about at the end and just being one little budget line item. Also, that could be forgotten or missed, or budget changes and they're cut completely. So really bringing them to the front of that is very important.
I agree, Nicole, and I think I saw a comment in the chat around partnership and coalition building being crucial. And I think one of the things that is helpful is when there are funding announcements that may go towards larger organizations, that things may get written in for there to be an expectation of meaningful engagement and partnership with CBOs as they do that, so that it begins to build that capacity. And as you mentioned, needing to have a $2 million budget to go after funding, building coalitions, true partnership with larger organizations, where then the benefits of that funding are both being shared between the larger organization and the CBO, I think is essential. And it takes support. It takes support to be able to identify who those partners might be, on how to develop outreach materials, engagement materials to build those sort of partnerships and coalitions.
If you're asking an organization for a letter of support, there needs to be dollars behind that, and then actually executing it after the award's been made. I've had that happen a couple times where, like, the award's made, the project's going and running, and you're like, wait a second, were we here having a conversation 6 months ago, a year ago, about this? So making sure that actually does happen is so important.
Well, that jumps me to a different question that I wanted to ask, and then I'll go back. But how can APT is a large organization. There are, I don't know, dozens of APT colleagues here on the line. Like, how can an organization like APT support an independent woman, single woman-owned consulting firm, Nicole Clark Consulting? How can we support a group like Mama's Voices, and how can we be good partners in the work that you're trying to do? Do you have any guidance for us and to our colleagues that are on the phone?
Nicole, I don't know if you want to go first or should I go?
No holds barred. Tell us. We're listening.
This has been a kind of an ongoing conversation for me. I've been consulting full time since 2016. And in the very beginning of my consulting practice, a lot of my projects were me just working by myself. And over the last few years, I've been partnering with other independent consultants or other larger institutions. And one of the things that I've been struggling with in regards to whether or not I'm a good partner for someone that I'm partnering with, or whether or not they're a good partner for me. And I think the key for me, or rather for App Associates, is reflecting on being a better partner in general. I think that means that understanding the roles and the skills you bring to the partnership, but also being honest about whether or not you should have a role in the process. And what I mean by this is that a few years ago, I conducted some qualitative interviews with some key players in maternal health and birth equity work. And one was an executive director of a nonprofit based in the South, I believe. And the executive director, she was frustrated because she was hired as a subcontractor to a much larger organization. And that organization had the internal infrastructure, but didn't have the expertise in the area that the executive director had. And so I feel like when it comes to organizations that are similar to Apple Associates, as you're thinking about the types of partnerships that you want to engage in, having some honesty around whether or not you may be the best place to hold the project. And if so, who would be the best partner for you, and how can you distribute that work in an equitable way? And also, if you aren't the best organization to hold the project, who can you refer the project to? There have been some times where I've been asked to be a subcontractor when it comes to projects that are more reproductive justice oriented. But my question is, why isn't there someone on your staff that already knows and understands this framework and how to implement it within your organization? So I think it's about understanding the role that you bring to the project, but also being honest about whether or not you should be holding the project. And just to close out with that, I do have a evaluation colleague that has built up a practice where if someone comes to her in the interest of working with her on a project, she will speak to them, but then she would also refer them out to other independent evaluators. And that's a practice that I picked up for myself. So even if I feel like I may be a good fit for the project, there may be someone else out there who can do a better job at it than I am. So just thinking about, there's tons of projects and everyone's trying to get these projects, but having an understanding that there's plenty to work on, and that it's more important to send the organization to the person who is a much better fit, as opposed to taking it on because you have the infrastructure for it. So I'll stop right there.
I think it's a great segue too, because one of the things that we do is we work to make sure that there is lived experience involved in projects. And so we have quite database and lists and roster are all the wrong words, but we have quite a community of folks that we have trained to do this work. And so we want to match those people that have experienced experts into the right projects as well. And so what that looks like, we're able to elevate more voices. We're able to amplify different experiences and different things. And so you might be able to connect with one point of contact that can connect you with others. And it's kind of the same mindset with connecting with CBOs, is that you have more visibility and you have more resources that you're able to connect with. So, just keeping that in mind, that it might look a little bit differently. Just though you go through the one entry point doesn't mean that's what it will end up being, but we're here all to support each other in programs and all the different voices that need to be heard, regardless of what the condition is. We're really condition agnostic, so we can bring those different perspectives in as well, and not just with patients with lived experience, but also different patient advocacy organizations that are looking to have a seat at the table and have their voices heard too.
That's great. Thanks to you both. And I think, I'm sure I'm speaking for others on the call, is that what you're also saying is very inspiring, because what you're doing is very focused on the purpose of our work. And there's enough work to go around to accomplish improved health and well-being for the populations here in the U.S. and abroad. So you haven't lost track of that, which I think is just always great to hear. So let me go back to a couple of other questions. I want to talk a little bit about for Nicole Purnell. What have you seen as some of the challenges for meaningful engagement of people with lived experience? And what are your strategies for helping overcome those?
I think one of the biggest things is that there's the expectation that you, as a person with a lived experience, you need to sound like a clinician. And that's not the role. And that's definitely not what we teach people, is that it's okay to ask questions, and definitely not there to know all the answers. And to be able to, coming into things like, oh, what's a QAPI? Like, not, you don't need to know what that means. That's not your role. Your role is to bring what happens in the real world, what happens when you go to these appointments, what's happening in your neighborhoods. That's what is important to bring to those conversations. And so for so long, it has been to have a foot in the door and have a voice at those tables. You needed to sound like a clinician. You needed to be polished. And there was this, we need polished people that are well qualified to be voices at the table. And we've been trying to break that down. And I feel like we're successful at that and bringing those in. So, we do train people with lived experience to be involved in projects, but it's absolutely not to have a full knowledge. It's how to share and how to be a partner in projects in a respectful and in a way that it's truly a partnership, and it's not just an advisor role or checking the box. So we really want to encourage that. And that's something that we do. And we have seen great success in that. So just keeping that mindset of it, everybody has a role, regardless of what they may sound like, what they might write like, what they may look like. They have a way and a place to be involved in that work. And those are probably the ones you really need to hear from, that don't look like what everybody else in the room looks like.
Okay. And Nicole C. There has been lots of strides made in more participatory or equitable evaluation. You've talked a lot about what your day-to-day is in supporting community organizations to drive their own learning. But I just want to give you sort of the space if there's anything else you want to talk about in terms of where do they struggle and what kinds of supports they need.
I think when it comes to evaluation, one of the things that I've seen community-based organizations struggle with is looking at evaluation as a means to an end. Like, we're doing this in order to prove to the funder that we made good use of the funds that they gave us. And I've been very fortunate over the last few years to work with organizations to build their own evaluation frameworks. And these staff members are self-selecting themselves into this process. So I kind of feel like a professor on one end, where I'm teaching them about the various stages of evaluation. And what's been really great about this process is not only did they self-select themselves into this evaluation committee, they take what they learn and they're teaching their other staff members in their departments. And they're using these various aspects of evaluation to improve how they do focus groups, how they do surveys, and thinking of other innovative ways to get data from program participants, but at the same time, inviting program participants to be a part of the evaluation process. And so I think one of the struggles is working with organizations to shift how they think about evaluation, and that is not, it shouldn't just be something that's a means to an end. It's something that they can use to not only learn about the actual program, but to learn about the communities, about their staff as well.
And Nicole, can you speak a little bit, because you mentioned this before, and it's also to a question here about sort of intermediate outcomes or initial outcomes rather than the outcomes of reduction of preterm birth or infant mortality and maternal mortality. How do you support community organizations to create their own theories of change and what they're trying to affect, and then how do you communicate that? Like, I imagine you also play the advocate role to the funders, or to craft this in a way so that it still is community owned. Can you talk? I have seen you do that. So can you talk more about your experience?
An interesting thing about you mentioned like theories of change. I noticed with the organizations that I've worked with, they're more open to theories of change. But when it comes to something like a logic model, there's a lot of struggle and resistance around that because I feel that in a lot of ways, logic models are something that funders made up in order for them to understand what the organization is trying to articulate with this program. And one of the things that I've been doing as an advocate for the organization is trying to work with funders to be open to the different ways that organizations want to present their work to them. It may not be a logic model, it could be a work plan. Like a lot of organizations have work plans that they develop to start off their fiscal year. And in a lot of ways, a lot of the things that I've seen in work plans also mirror a logic model as well. And so instead of giving organizations another burden to create a completely different product, why not use the things that they currently have at their disposal that they are able to articulate to the funder to express what the needs are and why they are creating the program and why this program is in existence.
Okay, I just got the 2-minute warning. We could continue to chat all day. Kelly, you haven't said anything. Do you want to share any last thoughts before we close up? And then also, don't everybody leave yet because we have one other announcement too. But Kelly, please.
I think it's I've been quiet and listening to the experts, especially around the question of how ACT and larger organizations can provide support. I think, to the points that both Nicoles have made, that being able to, as a larger organization, being able to work with and engage community-based organizations and provide some structures or resources around sort of developing systems. Nicole was talking about Nicole C. I said Nicole, it could be either one, around evaluation and logic models and not having to change and create something new. But I think, a lot of times we talk about one of the largest areas that community organizations need support is around that infrastructure piece. So how do you set up simple, reasonable, usable data collection systems within your community-based organization? Everyone does not need a massive data collection system. I love a good Excel spreadsheet. And so working with community-based organizations about how to do that, and then how you can utilize what you have to present it in different ways, whether that's around data, whether that's around qualitative information, the stories from the people that you're supporting. So that was, I think, my last tie-up thought was, helping community-based organizations leverage all of the strengths and expertise that they have.
That's awesome. Thank you, Kelly. Thank you, Nicole. In the last minute, I'll just let everyone know that several of us at APT have been working hard on a maternal health white paper, which we've just put out on our website. Daniela or Miriam, if you wouldn't mind putting the link in the chat. We recognize that this is just the beginning of the conversation. We'll take a longer look at people's comments and questions and maybe do a little sort of frequently asked questions or Q&A and put that onto our website as well. So thrilled to have everybody here, and huge thank you to Nicole, Kelly. Feel very fortunate to have had you here today and for you to share your wisdom. So thanks for your time. Take care, everybody.
Thanks, everyone.
Thanks, everyone. Bye-bye.